So this is Charlotte Pedley providing the screencast for the CT versus MRI referral criteria. So as you can see from the two images shown on the screen just here, you can see the MRI scan image on the left-hand side and a CT scan image on the right-hand side. And as you can see, different things can be visualised in greater or lesser detail. So what the plan is for this screencast is just to talk you through the advantages and disadvantages of CT versus MRI and when to refer for each, and which one will show you in greater detail the structures that potentially you will want to refer for. So the advantages of the CT, looks at imaging bone, soft tissue and blood vessels all at the same time. Can be useful for looking for bony injuries post-trauma, looking at the quality of cortical bone, looking for any calcification, for anything that we're suspecting in terms of lung or chest problems, detecting cancers or metastases, or imaging patients that are contraindicated to MRI, so those that potentially have metal implants or shrapnel, or potentially pieces of metal within the orbit. It's also quick and it's accessible. The advantages to MRI, used for imaging water-containing tissues, things like spinal cord, discs, nerve root damage, soft tissue. There's no ionising radiation with MRI, and you can also image in any plane. So therefore, thinking about the disadvantages then, so CT contains a radiation dose. So why would you choose to radiate somebody when you could do it via MRI? Whereas MRI costs more and is more time expensive. So CT takes around about 3 to 7 minutes. MRI scan can take up to about 45 minutes. And like I said, MRI is more expensive than the CT scan is. CT is suboptimal for soft tissue when compared with MRI. So doesn't give very much detail, doesn't the CT, when you're looking at soft tissue, but on the contrary, gives excellent detail in terms of bone. Thinking about the MRI scan, gives excellent detail in terms of soft tissue, but then really poor detail in relation to bone. Like we said before, there's a radiation dose associated with CT. Radiation for a CT is around about 10 millisievert, whereas MRI doesn't have any at all. Reasons that you may choose to not use MRI would be that you can get artifacts, so movement artifacts when the patient's breathing, metal artifact if there's something in there like an implant, such as, say, a total hip replacement. If you're trying to look at the lumbar spine, that's going to give you some metal artifact. And claustrophobia, the MRI scanners are really quite small and tight. So if somebody suffers from claustrophobia, they're not going to want to be sat in an MRI scanner for 45 minutes. So this table just outlines that in a little bit more detail. So you might want to pause here and just have a think about the pros and cons of each and just make a little table. And it's worth having this table printed out sometimes in your clinical areas. So you can just refer back to if you need to when looking for referring. Whenever we're looking to refer somebody, you should always be asking yourself the question. So if you do an exam where the results are given, whether they're positive or negative, is that going to alter your patient management or add confidence to your referring diagnosis? So is it going to change the pathway that the patient's on? And is it going to change your management of that patient? If the answer to either of those is no, then do we need to be referring that patient for imaging? If the answer is yes, then you would then move on and say which type of imaging is going to be most appropriate for my patient. So when looking at the referral that you're sending off, the radiographers are looking to triage it. So they're looking to accept or reject based on what you say. So the first question that they're going to ask is, does the referrer suggest the type of test or just the indication? So ideally, we need to be making suggestions as to what type of test we think is most beneficial, are going to give us the most weighting in terms of our clinical diagnosis or management plan, rather than leaving that to your colleagues. It may be worth a phone call ahead to say, I have this patient and I suspect this clinical diagnosis, which method of imaging is going to be most appropriate, and is it clinically indicated for me to do that? So the questions you might want to ask yourself is, has it already been done? And if so, how long ago was it done last? Is it required? Is it just normal degenerative change? If it is just normal degenerative change, it's having those conversations with your patient that this isn't going to improve, but you need to negotiate movement within their treatment plan. Is it required now? So has the disease progressed enough since the last image was done? Are we checking to see whether or not it's resolved? And if we are checking to see whether or not it's resolved, are we checking to see whether it's resolved because there has been no clinical improvement, or the patient's reporting no clinical improvement? And if so, is that going to influence our management of the patient? Probably not. Is this the best test to be performed? Have I explained what the problem is on the referral? Are there too many tests being done at the same time? So have you ordered blood tests? Have you ordered imaging? Have you sent away and done a clinical examination? And then gathering all that evidence together, do you actually need such a broad scope of diagnosis? Can you narrow it down into small sections? So perhaps you'll send away for the blood tests and see what that brings back. And if you're not getting anything back on that, then does that send me down a different pathway? Do you really need to send for everything all at once? And are there any contraindications? So on your referral, you should be giving correct and full clinical indication as to why you think the imaging that you're requesting is required. We need to ensure the patient receives the correct exam. So we need to ensure that you have the correct clinical reasoning for that. So, like I said, it may be worth a phone call ahead or discussion with a senior. So you're able to have those clinical discussions around your patient early on. So if you're not used to sending for imaging, it may be worth just taking a little bit of time out to bat those ideas amongst your colleagues to see whether or not what you're doing is justified. We need to reduce unnecessary exams, A, for radiation exposure if you're referring them for CT, but also for cost. So if you're referring someone for an MRI scan, we're trying to reduce the cost burden on the NHS at the minute. So again, is it indicated? Is it going to change your management plan? Have you looked at the evidence-based practice? So look at your local guidelines, look at your guidelines within your trust, and see what your radiology departments and your nuclear medicine departments want in terms of referrals for different conditions. And it might be worth drawing these up in conjunction with your radiology colleagues so that you have pathways for patients to go on to. So if we're thinking about the spine, if we're asking for a CT scan of the spine, we're suspecting trauma, or there is a history of trauma in the patient's subjective assessment, or there is a suspicion of fracture. For an MRI scan, you're thinking possible scoliosis. So are we going to correct the scoliosis? So is it pre-surgery? Are we going to be looking at spinal rodding? Are we suspicious of tumours, inflammation, any infection around the spine itself? Any thecal anomalies? Any suspicion of cord lesions, compressive lesions, pain with associated neurology for longer than 6 weeks that has failed conservative management? So in some trusts at the minute, that has to be bilaterally because that indicates your red flags. Unilateral, normally they will not give you an MRI scan because again, that doesn't change your patient's pathway. If you're suspicious of METs, obviously, with compression of the spinal cord or exiting nerve roots, and suspicion of ankylosing spondylitis. And you, in relation to your previous you had on blood tests, you'd be looking for a HLBA positive blood test result. So again, when we're talking about layering up investigations, is it enough to just have the positive HLBA, or do you need to also provide an MRI scan as well? If it is just pain that that your patient has, neither is justified. To have more clinical reasoning than just pain. And then when thinking about metastases, MRI is more sensitive and specific than CT would be. But thinking about that scan field of view, so how much are you asking that MRI to take in? Are you going to miss something if you zoom in on a certain aspect of the patient? So reasons that you would order an urgent urgent spinal MRI. If there was any suspicion of red flags, progressive motor loss, any widespread neurological deficit that included upper limb and lower limb, previous history of cancer. So thinking about the most likely areas of the body where people have had cancer that metastasise most frequently to the spine. So it might be worth here just pausing and having a think about and having a research of those areas that most commonly metastasise to the spine if you have had cancer. History of drug abuse, steroids, HIV, because we're thinking about the integrity of bone, and thinking about those that have got cauda equina symptoms, but these come under your red flags naturally when we're talking about urgent MRI scans. In relation to the shoulder, so if you have a patient coming with shoulder pain, you're going to think X-ray first. That's your first diagnostic factor. If you suspect shoulder impingement, looking at it from a clinical diagnosis, you wouldn't normally be requesting imaging for a shoulder impingement. Normally, if they are going down the pathway of surgery, then you'd be looking more at the MRI because you're thinking about the soft tissue visualization, and CT is not as good at showing soft tissue as it is bone. But only when surgery is considered would you want to be doing an MRI for the shoulder. And now the shoulder impingement surgeries are much less common. For shoulder instability, thinking about the type of shoulder instability that you have in front of you, are you going to be managing this conservatively, or is there a suspicion of previous trauma or shallow glenoid that's causing an issue with recurrent instability? So are we going to be looking at things like a Latarjet procedure? If we're not, then do we need to be imaging? And then thinking about rotator cuff tears, things like ultrasound scans to visualise the rotator cuff itself, potentially MRI scan. But again, if we're not going to repair, so if you've got an older patient and we're not going to repair that rotator cuff, then again, why would we be imaging? We can test that clinically in terms of strength into certain positions and ranges of movement. So is there any need to be imaging if we're not going to go ahead and then repair from there? Going on to think about the hip and the knee. So thinking about hip pain, avascular necrosis. So if the x-ray is abnormal, then you're wanting to establish the progression of the disease. So you can look at using an MRI if the plain film is normal, and nuclear medicine CT can be helpful with this, to look in a little bit more detail, because again, looking at the bone. So if there's an arthroscopy considered or soft tissue damage, then thinking about MRI because you're wanting to visualise cartilage or you're wanting to visualise soft tissue. Acute knee pain post-trauma, again thinking about soft tissue injury, so you're going to be looking at MRI. Any long-standing knee pain under the age of 50 where you strongly suspect that osteoarthritis is going to be negative, or it's come back from an x-ray that's actually negative, then you want to investigate in a little bit more detail. So again, MRI would be indicated here. So lumps and bumps, primary bone tumours, x-rays can characterise these, but MRI can be useful for further characterisation and thinking about the surgical staging, or thinking about the destruction that's happened within that bone. CT is better for looking at bony detail, such as some of smaller sites, like spine, if you're looking for smaller lesions. MSK tumour diagnosis and follow-up You'd be looking at MRI to stage these,